And our guest of honor is Steve, who was a stroke survivor and was cared for by Dr. Nguyen. We'll begin with Dr. Nguyen.
Thank you, Anne, and thank you, Twin, as well as a big thank you to Steve for joining us and sharing his story. So let's delve into this now. If my presentation will work. Okay, there we go. Okay, so the first thing to remember about stroke is you know, what the symptoms are. So that's the challenge, and if you don't take anything else away from today's talk, try to remember this slide. So first of all, what is stroke? Stroke is something that is sudden in onset. It doesn't happen over weeks or months, but it happens over minutes or hours at most. And a stroke, as we'll talk about, is a focal injury to the brain that results in any of these symptoms. And so a way to think about or try to remember these symptoms is through the acronym B.E.F.A.S.T here. And so B.E.F.A.S.T stands for the following, as you can see on the screen. B is for balance, difficulty with gait or walking, in other words, or any kind of difficulty with maintaining your balance or your sensorium. E is for eyes, meaning that whether it's a disturbance of vision or a loss of part of the vision or a total vision loss. F is for face, meaning weakness of part of the face or numbness of part of the face. That also includes headache and confusion. So just think of it as anything to do with the face or the head there. A is for arm, so weakness of the arm, but also of the leg. So any weakness, especially that affects one side of the body. So most commonly, a really easy way to try to determine this is to have somebody hold up their arms, and if one arm floats downward, then that might be a sign that there's weakness on one side. But it also can mean clumsiness or any kind of incoordination with one side of the body too. S is for speech. Speech both referring to the quality of the speech as well as the input and the output of the speech. So quality of the speech being if somebody has slurred speech and they've never had slurred speech before, or they have difficulty either understanding somebody else or difficulty getting the words out. Maybe they're speaking gibberish and you just don't know what they're saying. That could be a sign that they're having a stroke. And lastly, T is for time, with the message there being that seek help immediately, because as you'll hear about, we have certain treatments that we can potentially offer if stroke people can get to the hospital early enough. And so the quicker the recognition of a possible stroke, the better the outcome. Overall, it's important to understand how significant stroke is as a disease. Stroke is the #1 leading cause of disability in the US. And so as you can imagine, it leads to people not being able to maintain a normal sense of a normal life moving forward in some cases. And so that's really important to keep in mind, going back to the recognition and getting the help that they need as quickly as possible. Overall, stroke is the #5 leading cause of death in the US and #2 worldwide. And it also results in a significant, really high cost to the US overall in terms of healthcare dollars. So the direct costs associated with stroke, that is the costs that are associated with caring for people with stroke, whether it's the testing involved or whether it's getting them the rehabilitation they need, results in something along the lines of about $36 billion a year. And that's only the direct cost. If you add on top of that the indirect costs, and that is costs that are associated with people's loved ones having to stop their lives in order to care for people with stroke, that cost is even higher. So this is a substantial problem overall for healthcare is to try to deal with stroke, try to treat stroke as quickly and as aggressively as possible so that we can reduce all of these different things. Overall, in the US, about 800,000 strokes occur every year. Okay, so here's an example of what not to do. So this is a hypothetical case, but it's a case that we hear a lot of, or not too infrequently of. Let's say there's a man who develops a weakness on the left side of his body at about 10 o'clock at night. He mentions this to his wife, and his wife says, well, you know, why don't you go to the emergency room and get it checked out? But the weakness, at that time at least, is not super severe. You know, he might still be able to walk and handle things with his left side. So he thinks that it might get better, so he goes to bed. The next morning, unfortunately, when he wakes up, he finds that he's totally paralyzed and unable to move the left side at all. And so by that time, you know, certainly we still want him to go to the hospital, but by that time, it may be too late for certain treatments and he may be left permanently disabled. So this is a scenario that we hear, you know, again, not too infrequently, and and you know, the message there is, of course, that, you know, to get help as soon as possible. And you know, and also the second message is, you know, listen to your spouse or significant other. You know, you may not be surprised to hear that I hear that a lot, that, you know, patients who come into the hospital, you know, their spouses are at them because they didn't listen to them earlier, and unfortunately by the time that they do, it's too late. And so just, you know, listen to your loved one, go to the hospital as soon as you can. I can't stress that enough. So a few brief words on COVID. You know, obviously COVID and this pandemic is on everybody's minds, and it's affected us tremendously, obviously. It's also resulted in people not wanting to come to the hospital soon after an event like a stroke. And, you know, why is that? In part, it's because people are afraid of contracting the virus if they come to the hospital, right? We totally understand that fear, but you know, that is an obstacle that we're facing in, you know, again, getting stroke patients the care that they need, and you know, the delay in doing so again can result in disability. So try not to succumb to that fear if, God forbid, you're in that situation where you have a stroke, because we want you to get the treatment that you can to reduce the disability that you may face. COVID also has resulted in has been a cause of stroke itself. COVID has been known to cause strokes in not just people with the virus, but younger and otherwise healthy people who otherwise have no medical problems may contract the virus and may have stroke develop as a consequence of COVID. And so the therapies and the treatments that we have for stroke still work despite COVID. So we don't want people to think that, you know, if, you know, because of the virus, they shouldn't come to the hospital. Still, you know, come to the hospital as soon as you can. And the other thing that that I want to stress is that, you know, we do take this very seriously, that the virus, in other words, and anybody who comes into our hospital in whom we are suspecting stroke is tested for COVID, and we take extreme precaution to make sure that they don't contract the virus. So please come to the hospital if, or at least, at the very least, talk to your doctor or talk to somebody and get advice. So in terms of stroke, there are two different types of stroke. There's one type called an ischemic stroke, which refers to a clogged artery. And there's another type called a hemorrhagic stroke, meaning that the artery, an artery rather, has burst open and has caused blood to leak out into the brain. And so the ischemic stroke, or the blood clot type of stroke, is the more common type, and that's the type that you can see here on the right-hand side of the screen. And these are some examples. So here's a real live, or not live, but a picture of the brain itself with a stroke there in the back part of the brain. This middle part is showing a cross-section of the carotid artery, which is an artery in the neck. And as you can see in the middle of that picture, there's a narrowing here, and that's the narrowing of the carotid artery there. And down here is the cartoon showing a blocked artery in the brain. And on the left side of the screen is showing, these are examples of CAT scans showing blood here. That's the white area that you can see here in the three images. So when we're dealing with stroke, when stroke first happens, a blood clot can block an artery, but the brain that is supplied by that artery can still get blood supply through other blood vessels. Usually the brain is supplied by more than one artery, and so even if one artery is blocked off, there's redundant supply that can supply that area of the brain and help to lessen the stroke. But the issue is that if help is not sought in a quick manner, then those collateral arteries can give out, and that redundant supply can wear out, so to speak, and can lead to the stroke getting worse. And so the collateral supply is what allows the brain to sustain itself for a short period of time, but that short period of time is what we try to look for in order to give the therapies, any therapy that we can to try to reverse the stroke and try to break open a blood clot that may be there. And that's allowed us in recent years through research and through the technologies that we'll talk about to potentially offer treatment up to even 24 hours depending on the type of stroke. And so to put this another way, a group out of UCLA came up with some statistics to show the urgency of stroke. And so we like to say in the stroke world that time is brain, and so time is of the essence, right? So a group out of UCLA was able to calculate that every minute that passes after stroke, 2 million brain cells die with every minute that passes. On the flip side of that, every minute that we can save after a stroke, if we're able to get to the blood clot and help break it open, we may be able to save 1 day of healthy life in that individual. And so every minute counts when we're dealing with stroke. Okay, so we're going to talk next about the different types of treatments that we have for stroke. So the mainstay of treatment, so to speak, is a medicine called TPA, or tissue plasminogen activator. It's a medicine that is designed to break open blood clots, and it's been around, or it's been approved by the FDA rather, since 1996 for use in stroke. And so that treatment is again, a really powerful blood thinner that we can give to people with suspected stroke or with stroke. But the time window that we can give it is limited. Usually it's up to about 4.5 hours, but in some small cases, we can extend that window up to about 9 hours. And so the more research that happens and that takes place, the more we're pushing the time window, but the sooner the better in terms of giving this treatment. And so, as I mentioned, this blood clot buster has a limited time window. And so here's an example of that. Okay, so this is another hypothetical case. Let's say we have a gentleman who's a very heavy smoker, and he woke up at 4 in the morning with right-sided weakness. And then he arrives at his local hospital at 10 o'clock in the morning. So that's within 6 hours. So he might still be a candidate for that medication that we talked about. But the closest comprehensive stroke hospital is still 4 hours away. And so what do we do in this situation? And so he might be a candidate for that blood thinner that we talked about, but he needs to be evaluated more closely for that. So aside from that blood thinner that we talked about, what other options do we have that we can potentially consider for this patient? The one that you may have heard about in the recent few years is something called endovascular clot retrieval, or something, a technology called Stentrievers, or which stands for Stentretriever. And what that is that if we can identify a blood clot in the brain, an interventional specialist, an endovascular specialist, can actually take a catheter and go into the blood vessel all the way up into the brain to try to retrieve the blood clot with this really small catheter that has this Stentriever technology on it. So let me show you what a cartoon of that. So on the top panel, on the panel A here, is an example of this catheter. So it's a very thin catheter that you can introduce into the body, either into an artery in the leg or sometimes in the arm. And that artery, that catheter rather, can be snaked up through the arteries, past the heart, past the neck, all the way up into the brain. And so on the end of that catheter, the catheter reaches the blood clot, and the endovascular specialist brings that catheter through. And at the end of that catheter is this stent device that is opened up. It's almost like a chicken wire mesh kind of thing on the end of the catheter that they can open up and encapsulate the blood clot, and then they can pull it out of the artery and reestablish blood flow. And so this is a real picture of that. This is an X-ray in the catheter lab of a patient who had this procedure done. So this is the carotid artery down here on the bottom part of the screen, and in the middle part of the screen, with the middle yellow arrow, you can see this is the middle cerebral artery, and in the middle there, you can see that there's a loss of blood flow there in the middle there. And so if you look carefully, you can see a very small a catheter that's being snaked up, and that's what the other arrows are trying to show you. And then if you look really, really closely, you can see evidence of that stent being put in there and they're trying to open it up into that blood clot to try to retrieve that blood clot. So this is during the procedure itself. And then this next picture is showing that the end result, that the blood flow has been reestablished. And so, it's a remarkable new technology, or relatively new, I should say, that we're able to offer if people come to the hospital sooner rather than later. And we still have a time window that we have to work with, because if we wait too long, the brain may not be able to support and sustain a blood clot being taken out in this way. So we still have a limited time window that with which we can offer this this treatment too, if somebody qualifies for it. And this is the end result. This is a real live picture of that blood clot there, and with the Stentriever next to it, that catheter here. And so this is about 2.5 centimeters there, and so it's really remarkable what this technology can do. But it's not for all strokes, and it's again with only a certain time window that we're talking about, potentially up to 24 hours. And so that technology was approved for use in 2012, and it's been shown to be very, very effective in the treatment of stroke. But again, only if we can get to people within a fast amount of time. And this is an example of the type of room that a patient would be in if they're getting that procedure. So they're lying on top of this bed with an arm around it that has a small X-ray device. And as you can see on in the graphic there are small screens showing the actual blood flow there. And so the endovascular specialist is right next to the person controlling this device and trying to get that catheter up to the blood clot to take it out. Okay, so how are we able to get people to the centers that provide this type of treatment if they're eligible for it? So over the years at Sutter, we've been able to build a very extensive and very successful stroke network and stroke program through our relationships with not just Sutter hospitals, but with neighboring hospitals as well, to be able to get stroke patients to the right care and the right treatments that they need. And so how do we do that? You know, because the problem is that there aren't enough stroke specialists to go around. You know, we wish, you know, I wish that there were enough of us to be at every single hospital, but that just unfortunately is not the case. And so through things like telemedicine and through stroke technology, we're able to get to people quickly. And so this is an example of a telemedicine device where with a camera that we can use to control and to evaluate the patient quickly so that we can determine whether they need to be transferred elsewhere for their treatment or to get you know, the treatments that I discussed earlier. And so we have an extensive network throughout Northern California, and through our relationships, we're able to, you know, again, you know, our goal again is to try to get people the care that they need rapidly and safely. I'm going to try to be as brief as possible here because I want to get to to Steve's story and our questions and get to Eric as well. So I just want to mention really briefly that we also, as part of that, have very sophisticated brain imaging that we can that we do as part of this evaluation. So we have something called CT perfusion technology that can help us visualize the stroke, and this is an example of an acute stroke happening where the brain has not suffered permanent damage yet, and we're able to tell that through CT perfusion. And so, with going back to that example case, you know, that patient, you know, we could evaluate that patient through telemedicine to transfer them down to a center like ours here at CPMC for the Stentriever technology to help. And so that hypothetical patient made a complete recovery thanks to telemedicine and thanks to those technologies I mentioned. Okay, so in summary, remember B.E.F.A.S.T. We'll talk more about this in a second. And then I mentioned this in the beginning, but stroke compared to other things, you know, our job is also to try to figure out, you know, is this a stroke or is this something else that's like it? And what differentiates that oftentimes is that a stroke is something relatively sudden, minutes to hours at most, not days or weeks, not something that slowly or gradually gets worse usually. But when in doubt, try to you know, ask for help, ask someone for advice. If not, come to the hospital to get evaluated. And then this is just to show you also, you know, who actually is there to call for help when somebody has a stroke. And oftentimes it's the patient's significant other or family member. And so, you know, again, don't ignore your family, listen to them. They have your best interests at heart. And then the final thing I want to mention is what's the difference between a stroke and a TIA or a mini stroke. TIA stands for Transient Ischemic Attack. And the difference here is that a TIA is when somebody may have stroke-like symptoms, but they go away and the person becomes normal again. And we think that might be due to a blood clot that temporarily affected the brain. But you know, even if somebody has that, even if they're back to normal, we really encourage people to get help because that could actually be a warning sign for a full-blown stroke. So even if you return to normal, even if you encounter somebody that may have had a TIA and they're back to baseline, encourage them to get help as soon as possible because, you know, we want to try to reduce risk of further stroke and further injury moving forward. Okay, so yeah, so this is just to say, you know, reach out and call for help. Okay, and so with that, I'm going to turn it over to Eric Pancoska, one of our wonderful stroke coordinators here at Sutter.
All right, hold on one second. I'm just going to pull up the presentation. For those who were here at the beginning of the call, I had to swap rooms real quick, so I'm just going to quickly get this set up. Hold on one sec. Okay. All right, there. Sorry about that. Okay, so to introduce myself for those who have just joined the call or joined a little bit late, my name is Eric Pancoska, and I'm one of the stroke coordinators at Sutter Health and at one of their many different stroke centers across Northern California. We know that stroke prevention is something that is very important and that we really value with all of our patients. And we know how disabling stroke can be and the benefits of educating every patient on their risk factors and risk reduction practices. Today, I'm going to talk to you guys about stroke prevention and how you can decrease your risk of having a stroke. So let's start by looking at the 4 big treatable risk factors for stroke. We define treatable risk factors as risk factors that can be modified through either medication or lifestyle changes. Each of these treatable risk factors increase a person's risk for having a stroke, with blood pressure being one of the highest risk factors, followed by diabetes, smoking, and alcohol usage. If a person has multiple of these untreated risk factors or these risk factors and don't seek management of them, it will greatly increase the risk for having a stroke. Other risk factors that are kind of out of everybody's control are, of course, age, sex, race, and genetics all play into a person's risk for having a stroke. So now that we've seen kind of the 4 main risk factors, let's also look at the preventable medical conditions that are specific to stroke. So this specific figure looks at kind of the chronic medical conditions of around 731,000 different people. And when you look at the figures, you notice that about over half of them had hypertension and 20% of them had elevated cholesterol. And then of course, some of the other risk factors included smoking, atrial fibrillation or AFib, and heavy alcohol uses. And that being said, if these medications or if these medical conditions are managed well, we can definitely reduce that risk of stroke for all patients and get that 731,000 number down to something that's really kind of a lot more lower and more manageable. So how can we reduce the risk for stroke? Let's first look at medications. For some individuals, aspirins or more powerful blood-thinning medications will reduce your risk for stroke. These medications kind of help to prevent blood vessels from becoming blocked or narrowed and decrease the ability for the blood to clot in general, which, as Claude talked about with ischemic stroke, is one of the major leading factors. We also know from the other slide that uncontrolled hypertension and elevated cholesterol put a lot of those patients at risk and was definitely a comorbidity for those patients who had strokes. And so for individuals whose blood pressures are high, keeping it within a safe range is extremely important. And then also for patients who have elevated cholesterol, statin medications are oftentimes recommended to reduce one's total cholesterol or LDL cholesterol. And the easy way to remember what is the good cholesterol and the bad cholesterol is LDL is the lousy kind. Okay. It's also important to definitely talk to your healthcare provider about how to manage your cardiovascular and neurovascular health, and if these medications could potentially be beneficial at helping reduce your stroke risk. I also want to quickly talk also about some of the different type of treatments that have been either kind of said in the media or you can kind of oftentimes find online. And the first one I want to look at is kind of looking at hormone replacement therapy. Looking at kind of the data, there's no real definitive data to say that hormone replacement therapy is actually effective and actually in some cases could increase your risk for having a stroke. That being also said though, if you're on hormone replacement therapy or considering it for another medical condition, don't either stop it or be discouraged from taking it, but first talk to your doctors about kind of the benefits of you taking the hormone replacement therapy for another medical condition and kind of if there's different alternatives. As for kind of vitamins and herbal medication, there's no definitive data to say that they're actually good at preventing stroke or effective at doing so. In fact, with herbal medications, some have actually found to be harmful in certain cases because the herbal medications could either decrease the effectiveness of medications you're currently taking or make them too helpful and potentially cause side effects. Okay. For those specific reasons, whenever you start a new medication or a new supplement, definitely talk to your doctor and pharmacist about if it may interact with any of their medications that you're currently taking or how it may kind of affect you. Now, there's other ways to do it besides taking pills, and one of the big ones and main ones is exercise. Physical activity exercise has been shown to have lots of benefits across all cardiovascular health. Exercise means different things to different people, and I know for a lot of people, starting an exercise routine can be really daunting and very kind of difficult. The important thing about starting an exercise routine or increasing yours is find something that works really well for you, and that's something you can stick with. You know, starting to go from no exercise to 7 days a week is not going to be something that's going to be beneficial or even kind of achievable for you. Start with the first couple days and then kind of continue from there. Besides kind of the stroke effects from it, we know that it definitely will help also increase your kind of mood and memory benefits, along with decrease in blood pressure, weight control, and cholesterol, which we know are definitely one of the big contributing factors to stroke. And we recommend it kind of across the board, about 30 minutes a day, 5 to 7 days a week. But let's also look at some other ways that you can kind of reduce your stroke risk. As many people have kind of seen with cardiovascular, consuming alcohol can help kind of reduce your risk for potentially having cardiovascular or neurovascular disease. But there's specific caveats to that. And that is mainly consuming alcohol within moderation. And for men, that means 2 drinks a day. And for women, that means about 1 drink a day. And a drink can very much be broken down to 8 ounces of beer, 4 ounces of wine, and 1 ounce of hard liquor. With also regards to alcohol consumption strokes, studies have found that the same benefit is for consuming 1 drink a week as compared to having a daily drinking. In contrast, though, moderate to heavy consumption of alcohol will lead to hypertension, diabetes, obesity, AFib, and liver failure. And as we kind of discussed before, those are hypertension and obesity, along with diabetes, are huge risk factors in general for it. So within basic moderation or once a week is what is kind of recommended. Let's also look at diet, though. That plays a huge role in kind of reducing your risk factor for strokes. Nowadays, there's so many different types of diets. There's low carb, low fat, paleo, vegetarian. Everything's kind of been putting out there with either weight loss or kind of general health. The one that I want to kind of show you guys, talk to you about, is what's called the Mediterranean diet, because it is shown to be kind of effective at kind of decreasing your risk factors for both cardiovascular and neurovascular health. Looking mainly at the Mediterranean diet, we're focusing on eating lots of fruits, vegetables, nuts, and substituting white meat in the place of red meat. And this kind of figure here gives you a little bit of idea of what that diet consists of and how it kind of compares to a low-fat diet. And the reason why I'm showing you kind of the low-fat diet is oftentimes that is what is recommended, or that's what people think they need to eat in order to be healthy. And so I want to kind of show you how it kind of compares to, in this specific kind of New England Journal of Medicine article, or kind of figure about how this diet affected the risk for stroke over the last 5 years. And so this right here kind of is the figure that I want to pull up for you and kind of show you. Again, the control diet is the low-fat diet, and then the other one is the Mediterranean. And this kind of shows the effect of adapting a Mediterranean diet at reducing your stroke risk. As you can see, there's a substantial reduction in risk for having a stroke when you eat a Mediterranean diet, about 30% or so. And so even with increasing to have a kind of an extra virgin olive oil, or EVOO, has an even greater kind of risk for decreasing your stroke risk. That being said, though, similar to exercise, diet changes are something that are oftentimes take time, and they're not kind of an immediate jump into. And so if you choose to kind of modify your diet and adapt something similar to a Mediterranean diet, do it in small incremental changes, starting with a couple of meals a week, and then looking to kind of incorporate that into the long term, so you can build good, healthy habits instead of trying to change it all at once. And that kind of goes over some of the risk factors, what can be done to help reduce your risk. There's other multiple potential kind of things that can cause strokes, but as for preventable risk factors, these are the main ones that we like to educate and talk to our patients about. And so kind of concluding with everybody, as Claude said before, stroke is treatable, it's preventable. Time is of the essence with it, also contacting right away. And really, when you look at your modifiable risk factors, you're in control and you're able to kind of make a difference to reduce your risk. And that's something that I want all patients to know, that they have the power to prevent this from happening, whether it be, you're 30 years old or you're 80 years old. You have really the powers in your hands to make sure that you can prevent this from occurring. And that kind of concludes. And so we're going to kind of pass off to Steve. Steve's going to talk to us about it. This is, again, what we look at for stroke prevention. It's the B.E.F.A.S.T. And I'm going to leave this up here while Steve kind of talks about his story and how everything's going.
Sure. Is my camera up? Okay. All right. So, hey, thanks for having me. I really appreciate it. I guess that where I would start is, if I can have a stroke, anybody can have a stroke. I'm a triathlete. The night that I had a stroke, or the 2 hours before it, I did 500 burpees. So I'm thinking, hey, I'm pretty immune to this, right? Don't smoke, don't drink, 5% body fat. Been doing this my whole life. So it's fascinating. I think what saved me, besides having a partner who's smarter than I am, so I highly recommend that. One, listen to your partner. Two, if you find one smarter, that's really a good thing. But I went through that whole scenario that was laid out earlier, and it was an evening. It was 8:50 in the evening, and I remember lying there at 8:50, thinking, I'm kind of tired, I'm going to go to bed early, and I almost went and slept in a guest room. I was so tired, I had an early morning. And then 10 minutes later, it went from 8:50 to 9, my wife leaned over and said, say something. I wasn't saying anything. So I guess the good news is I got hit really hard. I still didn't know it was a problem, but my partner, my wife, recognized it. She literally pulled me up out of bed. And I got to tell you, I was thinking, what's the big deal? I just want to roll over and go back to sleep. And it was very bizarre. And I was sitting there thinking, maybe this isn't really happening, or it's not that bad. And she said, we need to get you to a hospital. And at that point, I couldn't speak. Right side of my face was droopy. I could barely walk. And she pulled me downstairs. And some of it was humorous, right? Because it was all on camera. We have cameras downstairs. And I wanted to put my belt on. And I wanted to put my shoes on. I was very obstinate about this, right? But she refused to let that happen. She said, look, we're going to get you to a hospital. And so she did the belt. My son threw on my shoes, and away we went. The other side of the FAST piece, I do remember this. She took the wrong directions to the hospital. So even with a very brilliant partner, she didn't exactly, I still remember this. I was like, I think she's going the wrong way. I couldn't tell her that, but she went the wrong way. So she had me to the local hospital in less than 30 minutes. So from 8:50 to 9 o'clock to, I do remember we walked in the hospital at 9, and I still was not comprehending how bad this was. Look, I'm not going to say stubborn, but I've learned to power through challenges, right? And I'm not very good at taking directions. And I'm like, hey, I can fix this. And she got me in there. They moved me through. They gave me the drug. I'm sorry, it's TPA. Is it TPA?
TPA.
TPA. And it didn't work. Apparently, this is pretty serious, right? And they had medvaced a couple of folks up from the San Francisco hospital. And within about an hour, hour and a half, they went through there, realized it wasn't getting better, it was getting worse, and they were rolling me out the door. And, my wife, who's very pragmatic, was already thinking, oh my gosh, I'm going to have to sell a house and get a 1-story, all these sort of things. But they got me so fast to San Francisco, went in and did a thrombectomy. Just amazing technology. I'm so blessed. Look, if you're going to have something like that today, the technology is fantastic. I didn't know it then, right? But it was basically, I was told it was a 14-minute surgery. And the probabilities of success are so great today with all the technology and the skill involved in getting there in the right period of time. I couldn't speak at all. I was thinking, literally, this is really bad. And one of the most joyous days of my life is I was in the recovery room, and I woke up and I went, oh my gosh, this catheter is killing me. And I got to say, the nurses and the team had to laugh, right? Because here someone comes in, has a stroke, can't talk, can't move, is paralyzed. And then, an hour and a half later, wakes up and is complaining because the catheter is bugging him, right? That's a great outcome. So look, truly blessed that my wife knew what she's doing. and that we followed directions and got where it needed to go. I speak for a living. I do podcasts, I do webinars, I do events. I'm a SVP of marketing. And I was laughing with my wife. I was going, I don't know what else I could do. I only have one noticeable skill, and that's the ability to speak. And because of what she did, because of the team, because how it all got done so quickly, you know, it restored me to my life. I think over the past couple of weeks, I'm not up to doing triathlons yet, but I'm easily doing, you know, 200 push-ups, 200 sit-ups. I'm not running yet, but I'm doing strong walks, and I've been back at work. And I think I'm 99% there mentally, which is fabulous, right? Look, I think I realize there will always be something. There's the before stroke and thereafter, but my quality of life is so sound, and back to doing the things that I love, not just personally with my family and what I can do physically, but to be able to get back to work and do something I love. So once again, like I said, I'm blessed. And I think a couple ways. One is my wife did what she was supposed to do. 2, I had a strong diet. And 3, I had an incredibly strong heart and blood flow. My resting heart rate was 42, 43. You know, my blood pressure is generally around 160. But I worked really hard at exercising. I'm not saying you have to be a triathlete, but I do think being in shape and having that strong heart and that blood flow, and you guys can tell me better than I can say it, but I think that was a big factor as well. But yeah, that's my story. I'm really glad to be here. So any questions or anything else that I can go down? I'm glad to answer anything. Or turn it back over to you, Docs. Any which way you want to do it.
Thank you so much, Steve, for sharing your story, and we're so glad and happy that you've made such a wonderful recovery. I just want to touch on a few things that you mentioned just to highlight, our message. One thing is, again, your wife being a big part of this, and again, listen to your spouse, but also, unless you're like across the street from a hospital, the safest thing to do is to call 911 and not to drive yourself to the hospital, because you don't know what other things might be going on. I know there's that temptation sometimes to do that, but the other thing is that unfortunately not all hospitals are created equal. So some hospitals have more capabilities for stroke than others, and so if you call 911, the paramedics will know which hospital that you might be better treated at. They're very well trained in identifying not just stroke, but potentially the severity of the stroke as well. And so, I also want to emphasize that it is a team approach, right? Because without not just your wife, but the staff and the nurses, physicians, paramedics, everybody who was instrumental in getting you to our center for that procedure, you wouldn't have, made that tremendous recovery there. So I want to emphasize that. And then you mentioned that TPA, didn't work in your case, and that's true. TPA, there are different types of strokes. TPA works for certain types of strokes and not others, and that's why we have the other technology to help us with that as well. And one other thing I wanted to mention before we get to the questions is that don't even worry about taking aspirin if you think you have a stroke. Let us worry about that for you, because you don't know. You may not know if you have, we don't know rather until we get that CAT scan whether you have had the ischemic type, the blood clot type of stroke, or whether it was a hemorrhage and whether there's actually blood leaking out. So if you take aspirin, that may make things a little bit worse potentially. So the best thing to do is don't even worry about that. Just call 911 and let us help you with the rest.
Yeah, I think the only thing I would add to it is that it's made me think about being self-aware. And I was lucky enough to have my spouse partner there to help me. But I think as we get older, you start to see, I'm 58 years old and very healthy, but there's still things that I could be aware of. And now I guess if I think about it, dialing 911 should have been the first thing if you start to feel those sort of pieces. And that's what I would encourage anyone. This is not about, making it through. This is about getting through, right? And being to humble yourself to say, I need help now. and call 911 and get there. Because it's fascinating to me. I travel all the time, all over the world. And in a normal circumstance, if it wasn't for COVID, I'd have been on the road in a hotel somewhere on a Tuesday night. And I was in such denial that I could actually have a stroke. I think it's part of our just understanding, look, we all have mortality face us, whether you're a triathlete or not. And I think my mental attitude toward that should have been or could have been very, very different. I'm praying I never actually have another stroke. It's my big goal in life, and we'll do whatever I need to do to make sure that doesn't happen. But I think that's a big piece of it, because not everybody's going to be lucky enough to have their loved one there to be able to take care of them.
Yeah, no, that's absolutely right. I mean, you know yourself the best, and and the B.E.F.A.S.T is what we want everybody to remember. But really, if you know deep down something is wrong, don't ignore that instinct. Get help, because B.E.F.A.S.T represents the most common symptoms for stroke, but it can also, stroke can also do other things that, are ton of other things. And so when in doubt, just, ask for help.
Oh, can I share? I have AFib,
Sure.
right? So one of the things, I'm sorry, the other part of my story is there was a reason behind it. And I have all this great data on my watch. And I had been in AFib for weeks. The problem was I didn't notice it. And I was like tapping my watch going, why is my heart rate at 150? My watch must be broken, right? And once again, all this great data is out there, but data doesn't do anything if you don't actually be able to make something of it and analyze it and be able to look at it. And I just totally ignore that. You look at your stress, you go through in those daily things that you're looking at. A lot of people have Apple Watches, or mine's a Garmin as a triathlete, but that data is really important. And I just wasn't doing a very good job. I think it just goes back to not paying attention to what things could be facing me at this age as I get older, and family history, right? I had AFib, and it was something that came through my hereditary, and I just never really done anything about it.
Yeah, and to add to that, in addition to, treating you for the stroke initially, one of the other goals that we do when people are in the hospital, in addition to helping people recover back to as close as we can to where they were before, is to try to identify that cause for stroke. Because if we can identify that and treat that cause, then we can prevent, to the best of our ability, future stroke from happening. And another thing you mentioned, you weren't expecting to have a stroke. I totally understand that. One of the questions that we got via email was somebody who was asking, why did I have a stroke if I was doing everything correctly, if I was eating correctly? This person did not eat any meat, had all of their, their blood pressure controlled, saw, their physicians, and still couldn't find a cause for their stroke. So number one, unfortunately, even in this day and age with all this technology, there is a small fraction of stroke patients in whom we just don't find a cause for the stroke. And despite all the testing, all the searching. And so I would, definitely ask that question though, if you happen, unfortunately, to have had a stroke, ask your neurologist, what they think the cause of the stroke is. And if they don't know, they should tell you that. But understanding the cause for your stroke goes a long way toward preventing a future stroke. And then the other point was that, even though strokes tend to happen in older people, we're finding now in recent years that not just because of COVID that I mentioned earlier, but just overall, even before COVID, that strokes, unfortunately, are starting to happen or starting to occur more in younger people in general. And we don't know exactly why that is, but it's happening. And so, even from day one of life, nobody's stroke risk is ever completely zero. It may sound a little scary, but the best way to prevent a stroke from happening is to see your doctor regularly, even if you're healthy. And as Steve mentioned, very, very importantly, don't ignore warning signs that your body's putting forward. With that, let me get to some other questions here. And again, thank you, Steve. I see a lot of thank yous coming into you for your story there. One other question is, how does one get back to driving? I've found that that's very confusing. So driving is a complicated issue in of itself. Certainly one of our goals is to get people back to as close to, you know, a lifestyle as they were before the stroke. And there are different types of strokes, different stroke severities. If we, for whatever reason, if your neurologist or you know, if I tell you that, you know, I think you shouldn't drive, that's because I really truly feel that way for you know, because I feel that, you know, your safety might be at risk or other people's safety might be at risk. And so it's not that we want to take that ability away from you, but in terms of getting back to the driving, it's more complicated because we want to make sure that you're fit for that. So oftentimes we will have you get an evaluation through a rehabilitation kind of center. There are certain facilities out there that have specific driving evaluations for people who have gone through something like a stroke or a medical condition. And so it depends on your specific situation. But if you're having to go through all of those evaluations, it's, you know, just keep in mind that it's because we want to keep you safe, and it's not that we don't want you to get back to that goal. You may be able to at some point, but we want to do what's safe for you and for others. Another question is neurooptometry recommended? I would say that depends on your type of stroke. So if your stroke affected the eye in some way, then you might need to see an optometrist or an ophthalmologist. I would talk to your neurologist or your other doctors about whether you need that. Because stroke, you know, as we talked about, can cause different things. You may or may not have an eye issue. Let's see, what's the recommended monitoring and follow-up post-stroke? That depends on what's happened and what the cause of your stroke and what your test results are. And usually if you're hospitalized, especially for a stroke, we will tell you what the follow-up is for, or what we recommend for that. And we'll usually reach out to you directly, or at least have the other doctors, you know, will tell you to come back in X number of weeks or months, for example. But it also depends on your type of stroke and what's happened. Steve, there's another question. What's been your treatment post-stroke? And you mentioned some of that. You got the treatment for the atrial fibrillation, right? Do you want to?
Sure. Yeah, we realized it was that I needed an ablation. It was probably, mine was pretty severe, and this, I didn't recognize it. Right there, there's AFib that comes and goes. I think as I was waiting to have the ablation, I think my heart rate was at 150 for 3 straight days. That's like crazy, right? It was actually, I felt phenomenal the first week after the stroke, and it actually went downhill until the ablation to control my heart rate. And it's been 3 weeks now, back in sinus, and started, you know, mine were like, you know, here's my 5 criteria I asked. What about sex? What about health, working out? What about wine? And what about coffee, right? The driving was at the end of that. But I had a list that I asked very much at the beginning. I was like, tell me in a very detailed plan, how can I get back to this areas of my life? And I will say this, I've been historically maybe not great at listening to doctors' advice on this. Let me tell you, I listened to doctors' advice. Your body could tell you, right? I was like, look, the team had done such an amazing job, both on the stroke and on the heart piece. I think my mindset is don't mess it up. Try to be a little bit patient. Try to live in that world of gradual progress. And that's really hard. You're talking about somebody who's doing a triathlon, you know, 3 months ago, and after the ablation, I could barely walk around the block for a day. But it's gotten really better every single day. And so, yeah, I'm super excited. But I wanted a plan, right? I want to know, when can I start to get back? Those are my 5. Everybody else has their own 5. But how do I start to create what do I want, and how do I get there? And working with obviously with all the docs.
Thank you, Steve. So there's another question: is olive oil encouraged or discouraged? Oh yeah, do you want to take that, Eric?
Yeah, I could for sure. I'm sorry if that. So the way that slide was showed, it showed both olive oil in both columns, and so olive oil is actually greatly encouraged. They found that if you kind of decrease your that specific oil kind of intake, that it didn't actually have not as great of effects. So definitely olive oil is something that is encouraged to use above all oils, and to have something regular in your diet as a preventative measure.
Great. Does Sutter Sacramento have the ability to provide the range of procedures to address strokes? Do you want to take that? I see that, Twin, did I see a thing that indicated that you wanted to answer that? I'm sorry. I saw something pop up there.
Dr. Nguyen, this is Ann. So
okay.
the answer to that is yes,
Yeah.
that Sutter Sacramento does have the capability to do the clot retrieval, the thrombectomies that Steve experienced.
Yeah. Thank you. Sorry, I just saw something come across the screen. Yeah, and to add to what Ann said, but again, don't try to go to the biggest hospital in your area. The biggest thing is time, right? So just, again, let the paramedics worry about the right hospital, and if needed, they'll, because not everybody needs that treatment that Steve unfortunately needed. So some people have more minor strokes that can be treated just as well at their local centers. So, we'd rather you be treated as quickly as possible. Just keep that in mind.
And Claude,
yeah.
I just want to add on to that. There's been a lot of stuff that's kind of come up in the news about, COVID and hospitals being inundated. And I know that it's a concern as a patient to say, I don't want to go to a hospital and, have to wait and potentially get COVID. And I can tell you here across there that we take this very seriously. We have specific protocols put in place for making sure that all of our stroke patients are treated rapidly, quickly, and safely. And so I want people to know that it's definitely important to come if you're having a stroke, and not to be discouraged by kind of the media saying that, you're going to be waiting on long lines and that there's potential problems. And so that's just one of the main messages we want to get out across to everybody, to come to the hospital right away and know that that's an important preventative measure.
And I'll say my experience was, in our local hospital, they knew I had a stroke. Everybody knew I had a stroke except for me. And they were very quick to act on that and make it all happen. And once that process started going and it started rolling, they took great care.
Thank you. So we're at noon, but I think we can go for another 10 minutes so I just want to very quickly try to get to as many questions as we can. So there's a question about, a comment about somebody having a cryptogenic stroke at age 44 and with something called a PFO, or patent foraminal valley. And thank you to CPMC. And thank you for that comment. That really means a lot. And a PFO is one other type of cause for stroke in some people. Steve, I read in Lancet about 4 years ago that marathoners and super athletes like yourself are more susceptible to heart attacks. Do you know if this is also true for stroke? It can be indirectly, because if going along that line, if there is a heart issue, it can lead to a stroke issue. So it's more complicated, but potentially, if anytime there's a heart issue, that might lead to a stroke.
Well, and I got to say, I put off the heart thing. I knew that my mom died at 63 from a heart attack, and I knew that, and I had gone to a physician 6 weeks before. But this is really hard. We're in COVID, right? It was a Zoom meeting, and so I'm showing up on a Zoom meeting with a doctor, and I'm saying, "Hey, my standard heart rate is 42. I'll show you the data," and they're like, "You're probably fine." Knowing what I know, family history, I would have gotten an EKG or gone in a little bit earlier. I mean, if I look back on it, there are things I could have done to know that maybe I needed to look precautionary a little bit ahead of time. But I got so caught up in, I'm healthy as a horse. How can there be a problem? And if I could do it over again, I would be a little bit more proactive.
Another question is cannabis smoking a risk like nicotine? Are cannabis edibles a risk? I would say I would probably ask your neurologist specifically about your specific circumstance with that, because there are other things that cannabis is being used for in medicine, but it's more complicated than I can give a direct answer for with that. My neurologist referred me to a stroke specialist since he didn't have an answer. Would you recommend that I continue to see the neurologist, my stroke specialist, or both? It depends on the neurologist. I would talk with them and see, because it depends on the situation. Sometimes people don't need to see us in stroke forever, and they can go back to their general neurologist, but it depends on your situation. Eric, do you have there's a question about the diet chart of the X and Y axis?
Yeah, let me pull that back. Mm-hmm.
And then it's, yeah.
Okay, so let me explain the X-Y axis. So the X-axis is showing over the years how kind of the incremental risk for between 0 and 5 years, while the Y-axis looks mainly at your kind of the increased percentage of risk as time goes on. So there was a study of, I think, over 50,000 different individuals, and so that's why there's such a small incremental percentage increase. But based on the control diet and on the Mediterranean diet, there said that there was definite a decreased risk from it based on that over a 5-year period. I'm sorry that wasn't initially understood when I initially presented the slide.
Oh, thank you, Eric. As a stroke survivor, am I considered high risk? Well, anytime somebody's had a stroke, that does increase your risk for a future stroke in general. But the best way to mitigate that risk is to, as Steve mentioned, keep being diligent and following with your doctors to make sure that we try to address every little thing possible. And that also kind of branches into some other questions that are coming through about, why am I on cholesterol medication if my cholesterol is okay? And that's because cholesterol medications like statins can have other effects. They can help reduce inflammation. So I would just, talk with your neurologist about that. If TPA is too late for you, can aspirin still be given? TPA is the acute treatment that is something that we only give in the first few hours. Long-term though, most likely things like aspirin will be part of the treatment course. So it's not, they're not exclusive. Are stroke survivors deemed high risk for COVID? COVID, as you may have read about, does seem to affect people more severely if they have medical conditions, and that includes stroke. So especially older people with pre-existing medical conditions are potentially at higher risk for developing COVID. And that's why, social distancing and taking all these precautions with masks and a good hygiene is very, very important, even if you might appear asymptomatic, because you don't want to, indirectly, affect somebody who's at high risk. And also to add to that, these people who have, medical history or are older may not have the usual manifestations of COVID. They may not have respiratory symptoms when they come into the emergency room, and their manifestations may be something else, like a stroke that happens. There's a question about whether Steve is on a statin and aspirin. Do you want to answer that, Steve?
Yeah, the one thing I'm taking now is blood thinner and Eliquis, and I have no intention of going off of that, right? The heart thing is one, but everything I can do to avoid having a stroke, I will do. It's not slowing me down. Sure, there's risk rewards to everything, but even after doing the ablation and making sure that I'm in sinus, I'm going to be super cautious and work with the docs, in particular around the blood thinner. And my main goal in life is to never have a stroke again, whatever that takes.
Okay, sorry, let me just try to speed through these last ones. So is cholesterol a risk factor for hemorrhagic stroke? Some older studies have shown that might be true, but the other studies have sort of negated that. So, I'll just say, also to talk to your neurologist about that if that's a concern, because some people have had both hemorrhagic and ischemic stroke. So if you have an ischemic stroke, it's important for you to be on on tight cholesterol control too. So it's not always black and white, so to speak, in terms of that. So it's very individualized. I'm a 20-year stroke survivor and very much recommend going to a stroke support group. Do you encourage them? Absolutely. The caveat being, it might be sometimes if you're a younger person who you know, because usually a lot of the stroke, you know, since stroke affects more older people, you might feel like, you know, is this the right group for me if you're a younger patient? I would try to, you know, ask your neurologist, because there are sometimes groups out there geared toward younger people, but in general, stroke support groups are good a source of information, just like today, because there are a wide range of topics that we haven't been able to get to. I also saw a comment about the mobile stroke unit helping to deliver care, and I'm so happy for you that you were able to get your treatment through that. That's one of the technologies that is sort of being, it's a very new technology that's being tested. It's at the hospital where Eric works. It's centered out of there, but it services the whole peninsula. And so it's a way for us to get this treatment to people quickly. And so as time goes on, hopefully there will be more of these stroke units out there to help. So I think we'll probably leave it at there at that.
We would probably not have enough time for all the questions and really wonderful responses, and especially Steve, really hearing your powerful story that brings it home. So we appreciate your time. And there are many stroke support groups in communities. Reach out. You can always reach out to American Heart, American Stroke. Reach out to your local hospital. Many ways to stay connected, and we're trying to have the in-person meetings become virtual, just like this. So we're happy that that's going to be something that is one good thing that has come out of this time period. Especially, we were going to be doing another event in October for International Stroke Day. So we'll look forward to seeing information about that.
Thank you so much, Anne, and thank you to our speakers. We hope that you, our attendees, found this presentation to be helpful, and not just you, but for your loved ones, as today's one of the biggest themes today is how important it is to have the people around you aware of the signs of stroke, because oftentimes they're the first one there. I also want to echo something that Eric mentioned about diet and its important role in managing your risk of experiencing a stroke one day. Community health resource centers, clinical nutritionists work closely with stroke patients to provide guidance on improved diets, such as the Mediterranean diet. If you're interested, please feel free to email that address that you received with your Zoom confirmation. That's how you can get in touch with me. We are accepting virtual appointments with our registered dietitians. And we also have a stroke support group hosted by a licensed clinical social worker.